Welcome to our Dental Classroom Pharmacology lectures. I am Dr. Sumathi Jones, Professor and Head, Department of Pharmacology. Today we will move on to immunosuppressants. So what is immunity? Immunity is the state of sufficient biological defense to avoid infection, disease or any other unwanted biological invasion. It is the capability of our body to resist harmful microbes or any other foreign particles from entering in. Immunosuppressants inhibit or prevent the immune response. Almost everyone who receives an organ transplant will take immunosuppressant drug. The body recognizes the transplanted organ as a foreign mass. This in turn will trigger body's immune system. By weakening the immune system, by giving immunosuppressant drugs, the body's defense is reduced and the drug will allow the transplanted organ to remain healthy and free from damage. So what is autoimmune disease? So autoimmune disorder is a disease process in which the body attacks its own tissue. Lupus results from such a misdirected activity of body's own immune system. By suppressing this reaction, immunosuppressant drugs can help control the impact of disease on the body. So we all know that immune system, we do have acquired and innate type of immunity. Acquired immunity is T cell mediated and B cell immunity, and innate is blood-borne or through physical barriers. So what is an antigen? It is any foreign particle. So what will antibody do? Antibody targets and functions. Coming to antibody functions, binding of antibodies to antigens will inactivate antigen by neutralization reaction, agglutination, precipitation of dissolved antigens or activation of complement system, which in turn will lead to cell lysis, or it can enhance and cause phagocytosis process. Coming to antigen-antibody reaction, how will it occur? The antibody gets attached to antigens, or it can cause pathogens to clump together, or it can activate the complement protein. Coming to types of antigens, we do classify antigens into exogenous antigens, endogenous antigens, autoantigens, tumor antigens or neoantigens. Exogenous antigens are antigens that have entered the body from the outside through inhalation, ingestion or injection. Endogenous antigens are antigens that have been generated within the previously normal cells as a result of normal cell metabolism because of viral infection or any other bacterial infection. Autoantigens is usually a normal protein or complex of protein that is recognized by the immune system of patients suffering from a specific autoimmune disease. Tumor antigens are neoantigens. These are presented by MHC1 or MHC2 molecules on the surface of the tumor cells. These antigens are presented by the tumor cells and then they are also called tumor specific antigens. Coming to types of antibodies, we do have 5 types of antibodies: IgA, IgD, IgE, IgG, IgM. IgA is found in mucus, saliva, tears and breast milk. It protects against pathogens. IgD, it is a part of B cell receptor. It activates basophils and mast cells. IgE, it protects against parasitic worms. It is responsible for allergic reactions. IgG is secreted by plasma cells in the blood. It is able to cross the placenta into the fetus. IgM, it may be attached to the surface of B cell or secreted into the blood. It is responsible for the early stages of immunity. So immune activation cascade includes 3 signals. It is a 3-signal model. Signal 1, it constitutes T cell triggering at the CD3 receptor complex by an antigen on the surface of an antigen presenting cell. Signal 2, it is also known as co-stimulation. It occurs when CD80 and CD86 on the surface of antigen presenting cells engage CD28 on T cells. Both signal 1 and signal 2 will activate several intracellular signal transduction pathways, one of which is calcineurin pathway. So coming to the drugs, we do classify drugs into drugs that interfere with the production of IL-2, that is calcineurin inhibitors, co-stimulation inhibitors and mTOR inhibitors, antimetabolites, corticosteroids, biologics. Coming to first classification, drugs that interfere with the production or activity of interleukins 2. These drugs will interfere with the production or activity of IL-2 and will dampen the immune response and will decrease the graft rejection. So, these drugs are further subdivided into three categories: calcineurin inhibitors, co-stimulation blockers and mTOR inhibitors. To start with calcineurin inhibitors, cyclosporin is a calcineurin inhibitor. It is a lipophilic cyclic polypeptide and it is a specific inhibitor of T cell mediated immunity. The drugs includes cyclosporin as well as tacrolimus. The mechanism of action of these drugs are, in general, T cell activation via antigen triggers increase in the intracellular calcium. This calcium will activate calcineurin, a phosphatase. The calcineurin dephosphorylates NF-AT, which is nuclear factor of activated T cells. NF-AT then enters the nucleus and stimulates the IL-2 gene transcription. So, the T cell gets activated, calcium level increases, this in turn will activate the calcineurin which will dephosphorylate NF-AT. Coming to calcineurin inhibitors, these drugs will inhibit calcineurin and prevent IL-2 production. So, T cell activation is blocked. Coming to cyclosporin, it binds with the binding protein cyclophilin and inhibits the calcineurin, whereas tacrolimus calcineurin by binding with FKBP12 binding protein. Pharmacokinetics of calcineurin inhibitors are, they can be given either orally or intravenous infusion. It is well absorbed, metabolized by cytochrome P450 group of enzymes. About 50% of the drugs are bound to erythrocytes and it is mainly excreted through fecal matter. Main use of calcineurin inhibitors are organ transplantation, which includes kidney, liver or heart transplantation to prevent rejection. It can also be used in autoimmune diseases like rheumatoid arthritis, psoriasis, atopic dermatitis, uveitis and nephrotic syndrome. Adverse effects of calcineurin inhibitors are, for cyclosporin, mainly causes nephrotoxicity, which is dose dependent, can cause tremor, hyperlipidemia, hirsutism, gingival hyperplasia. Tacrolimus can cause nephrotoxicity, tremor, hyperglycemia. It can precipitate diabetes mellitus and alopecia. Next is co-stimulation blockers. Co-stimulation blockers like beta-lecept, a second generation co-stimulation blocker, is a recombinant fusion protein that targets signal 2. It is used for long-term maintenance of immunosuppressive therapy. So, coming to mechanism of action of co-stimulant blocker, belatacept blocks the CD28 mediated co-stimulation of T lymphocytes by binding with CD80 and CD86 on APCs. This prevents the downstream stimulatory signals which promotes the T cell survival, proliferation and IL-2 production. So, mainly they block the signal 2 pathway. Coming to uses, belatacept is used for kidney transplantation in combination with basiliximab, mycophenolate mofetil and corticosteroids. This is preferred in place of calcineurin inhibitors to avoid cardiovascular, metabolic or renal complications. Third classification under IL-2 reducing drugs are mTOR inhibitors. mTOR stands for mammalian target of rapamycin. It is a serine or threonine kinase protein that plays a central role in cell growth, proliferation, survival and metabolism. It functions via two complexes, mTORC1 and mTORC2. Examples of drugs which are included in mTOR inhibitors are sirolimus. Sirolimus is also known as rapamycin and everolimus. Coming to mechanism, mainly they will block the T cell proliferation via mTOR inhibition. T cell activation will stimulate the mTOR pathway. mTOR controls the cell cycle progression and clonal expansion of T cells. In addition, it can also influence B cell differentiation and antigen presentation. So, the mTOR inhibitors will target mTORC1 and will block the IL-2 driven T cell proliferation. Next classification of drug is antimetabolites. Antimetabolites are structural analogues of purines, pyrimidines and folic acid. So, they will interfere with the DNA or RNA synthesis and will prevent cell proliferation. They'll particularly target the rapidly dividing immune cells like activated T or B lymphocytes. Examples of the drugs are azathioprine, which will inhibit the purine synthesis, mycophenolate, which will inhibit the IMP dehydrogenase, methotrexate, which is a folic acid analog, and leflunomide, which is a pyrimidine synthesis inhibitor. So, in general, these antimetabolites will interfere with the nucleotide synthesis and will reduce the lymphocyte proliferation. Uses of these drugs are, they are preferred in organ transplant, lupus nephritis, rheumatoid arthritis, psoriasis, autoimmune hepatitis, inflammatory bowel disease. Adverse effects of these antimetabolites are bone marrow suppression, hepatotoxicity, GI upset, teratogenicity. Next we move on to corticosteroids. Corticosteroids are glucocorticoid hormones that suppresses the inflammation and modulate immune responses by affecting gene transcription in the immune cells. Corticosteroids are further classified into short-acting, intermediate-acting and long-acting. Short-acting is hydrocortisone, intermediate-acting is prednisolone or methylprednisolone, and long-acting is dexamethasone, betamethasone and so on. Coming to the mechanism of action of corticosteroids, they bind to the glucocorticoid receptors, gets translocated to the nucleus, they will modulate the transcription process. They will reduce the pro-inflammatory cytokines like IL-1, IL-2 and TNF-alpha. They will increase the anti-inflammatory proteins like annexin A2. Overall, they will suppress the T cell activation, B cell differentiation, macrophage function and inflammatory mediator release. Main use of corticosteroids are in organ transplantation, autoimmune disease, inflammatory condition, hematological disorders and in COVID-19 in moderate to severe cases. The common adverse effects of steroids are hyperglycemia, increased infection risk, osteoporosis, cataracts, mood changes, gastritis and adrenal suppression. Next we move on to biologics. Biologics are large complex molecules designed to target specific components of the immune system. They offer selective immune modulation. Basiliximab is an IL-2 receptor blocker. It is mainly preferred in kidney transplant. Rituximab will target CD20. It is preferred in rheumatoid arthritis and systematic lupus erythematosus. Adalimumab is a TNF-alpha inhibitor. It is preferred in rheumatoid arthritis and irritable bowel diseases. Coming to the mechanism of action, they do block the pro-inflammatory cytokines, inhibit T or B cell activity, interrupt the immune cell trafficking and inhibit the intracellular signaling pathways. Main use of these biologics are in rheumatoid arthritis, psoriasis, psoriatic arthritis, inflammatory bowel disease, multiple sclerosis, systemic lupus erythematosus and organ transplant rejection. Adverse effects of these biologics are infection, reactivation of TB, herpes zoster or fungal infections can occur. During infusion reactions can occur like fever, rash and hypotension. Malignancy risk is common with these biologics. So, what are the common uses of these immunosuppressants? Immunosuppressants are mainly preferred in organ and tissue transplantation. Mainly these drugs are used to prevent and treat graft rejection. It is most commonly used in kidney, liver, heart and bone marrow transplants. The commonly preferred drugs are cyclosporin, tacrolimus, mycophenolate, azathioprine and basiliximab. Next use is in autoimmune disease. It is preferred in rheumatoid arthritis. The drugs preferred are methotrexate biologics, systemic lupus erythematosus, azathioprine and cyclophosphamide is preferred, psoriasis, methotrexate and cyclosporin is preferred, inflammatory bowel disease, azathioprine and infliximab is preferred, multiple sclerosis, fingolimod and natalizumab is preferred, myasthenia gravis, azathioprine and cyclosporin is preferred. Third use is it can be used in hematologic and immune disorders. So, aplastic anemia, the drug preferred is anti-thymocyte globulin cyclosporin. Autohemolytic anemia, steroids and rituximab is preferred. Vasculitis syndrome, cyclophosphamide and rituximab is preferred. Other emerging or off-label uses are in COVID-19 cytokine storm, tocilizumab was used. For ocular inflammation, methotrexate and mycophenolate are used. For nephrotic syndrome, cyclosporin and tacrolimus are used. So, coming to the adverse effects, it can cause opportunistic infections, TB reactivation, anemia, leukopenia, nephrotoxicity, hyperlipidemia, lymphomas and skin cancer. So, we should constantly monitor CBC, liver and renal function test, blood pressure, glucose and lipid profile, and also the drug levels. So, what will be the take home message? Immunosuppressants are required for organ transplantation reaction and to treat autoimmune disorders, but then it should be cautiously used. Target specific drugs should be used as there are chances of increased risk of infection, cancer and organ toxicity. Monitoring and individualization of the drugs are critical. That brings to the end of the session. Let's meet in the next class. Thank you.